Michael in this presentation, and we thank you for your time, Dr. Michael.
Thank you. So I'm going to share. Okay. Thank you for that, Miguel, and thank you for inviting me to this conversation series. It is my pleasure to be here, and today I'm just going to quickly give you a short insight into the role of mathematical models in trying to forecast and manage, pandemics. And here we're going to focus on COVID-19, the current pandemic. And I'm going to keep this at a very conversational, kind of level. So, and I know that following this presentation is where the real engagement will begin. So, any questions that you have, please, don't feel shy to ask. Okay, so this is work done by my group, and here I want to give a shout out to Ken Newcomb. He's my postdoctoral researcher. He's done a lot of this work that you're going to see. And on top of that, we have also other people from Notre Dame and also here in USF IT who support some of the computational aspects of the work. So why model, a pandemic, and why are models important to try, for management of a pandemic? The first thing to to be aware of to recognize is that, the COVID-19 pandemic has resulted in very unprecedented, interest in the use of models for conducting outbreak analysis, and in particular for forecasting the future course of the pandemic. We are, this pandemic is highly complex. It's got many moving parts, and mathematics is one way that we can put all this together and try and forecast the future. And one of the reasons why, policymakers have moved in, have looked at mathematical models is that, the pandemic has led to huge health and economic impacts, in societies across the world. It has also, given rise to, changes in global communication. We've got lots of portals out there, dashboards. So many people are beginning to be aware, of the progress of the pandemic across countries. And that is, due to technical advances in computational science. For example, if you compare the current pandemic with previous pandemics, we know a lot more. We can track what's going on with cases in different countries across the world, more or less in real time. And then there's also technical advances in infectious disease modeling. So all of this has contributed and made, policymakers aware that models can allow us to make some predictions about the future of the pandemic, and that can allow them to develop policy. And like I said, a lot of technical advances, there are new modeling methods that the pandemic has forced us to think about, and has improved computational tools, especially in data science. And then there's a lot of public data sharing, improved code availability that many people can now access code very quickly, that different teams are using, and therefore we can put together a model very quickly. And also now, better visualization methods, which is a way to engage with policymakers and also to the wider public. Another key factor is the role that models have played in policy response to previous pandemics. So policymakers are aware that models can be useful. It's not completely precise, but they are useful. And the models began to come to the fore when we started looking at influenza A pandemic in 2009, avian influenza H5N1, and then with SARS, CoV1. So, in developing policy to those pandemics, models played a role, and that's why now models is at the, forefront of many of these predictions. So how can models play a role during a pandemic? Pandemics can be divided into several stages. You got the early stage, and as the pandemic takes hold, which is the intermediate kind of stage, and then the late stage, which is recovery, right? So at the early stage, models can allow us to gain a better basic understanding of transmissibility of a particular pathogen and also risk of spread in a region. So models are very useful to do that kind of analysis. But it can also ask us to look, can we prevent the pandemic from coming into a particular area? What are the methods that we should be looking at? And we can model that kind of methods as well. But when the pandemic takes hold, and this is going to be the focus of my talk today, we start switching to containment and mitigation measures. And for that, we need to forecast the epidemic incidence rate, hospitalization rate, and mortality rate. We should have models to make those kinds of forecasts. We should be able to forecast the impact of various intervention and control strategies that can also change over time. So you need a very agile tool to make those kinds of forecasts. And this could be, non-pharmaceutical kind of interventions, social measures, physical distancing, face masks, to vaccinations. And we also need a tool to gain a better understanding of the impacts of changes in social behaviors. And this is very, very difficult to do. And because these behaviors will affect, compliance to public policies. So how do we track changes in social behaviors? And what impact will that do on the pandemic? And then we also, at the back of our mind needs to have tools, a modeling framework that will allow us to simulate new transmission conditions, such as emergence of virus variants, for example, which is the most recent problem in COVID-19. And then we switch to the late stage of a pandemic. And here our focus switches not to containment and mitigation, but to recovery. How do you recover from the pandemic? And models can be very useful, and you'll see some examples later on for modeling, the optimal recovery strategies. And then the last thing that models can do is to forecast longer term impacts. And this could be health, but also, keep at the back of your mind, economic recovery as well. So, there are many models for pandemic forecasting. I want to quickly go through some of those models. I'm not going to spend a lot of time. Statistical machine learning models you've heard about. They are dependent on the quality of data. It's very difficult to accommodate, time periods with no data, difficult to directly assess, impacts of interventions. They can make some forecasts, but these are not mechanistic. These are pattern-based forecasting systems. But here I want to focus on, causal or mechanistic models. These are the dynamic mathematical models that we are developing, and you're going to focus. We are going to focus on in this particular um, um, talk. These are process-based models. The design is coming, understanding transmission processes. It can simulate, transmission dynamics as a function of non-linear and very complex interaction between different groups which are involved in transmission in a community. They can estimate, the basic or effective reproductive number, which policymakers normally use to see, whether the pandemic is growing or declining, over time. It can also simulate interventions much more directly. Even the mechanistic model, they require data on transmission structures or knowledge on transmission processes. You need data on population size, initial conditions. Sometimes, and many of these models need, and you'll see later on why this is important, regular updating with data. And also, like I said, agility for incorporating new model structures rapidly because conditions are changing all the time. But many of these mechanistic models also captures one important feature of pandemic dynamics. It captures the co-evolution of social behavior and the pandemic response. What do I mean by this? If you look at how pandemics evolved, in a society, as cases increase, there's fear in society. So so they will start complying with social policy measures, right? And by increased compliance with social policy measures, the cases will begin to decline. But as cases decline, the response from society is that they will lose that fear. They will become relaxed in compliance with social measures, and what that will do is cases will begin to increase. So this interaction between social behavior and pandemic is really important, and mechanistic models allow us to capture that. So we started in March 2020 last year, when I was at Notre Dame. I came to USF in July last year. We started thinking, oh, we need to start modeling COVID-19. And so we thought that, in order to really make a difference to the prevailing models at that time, which was done at the national or state level, we thought we'll build mathematical models of virus transmission dynamics at the local level, because we thought those are the models that will play an increasingly important role for response planning, in managing the COVID-19 outbreak. We started focusing on what is known as the SEIR compartmental models. This we thought, these are the models that we need to build, because we need to build the models, but those models need to account for local transmission conditions, including impacts of locally applied social interventions, because those are the models that can facilitate, the forecast of the cause of the pandemic. We also thought our models need to be able to inform hospital capacity and resource planning for meeting the expected demand for beds, ventilators, ICU units, etc., etc. So we thought, if we build these models, those models cannot be static, because conditions are changing all the time. So we need to update those models, and we use Bayesian calibration methods to select and update ensembles of best fitting, locally acceptable models sequentially as data on the local outbreak evolves. Okay. And because these are ensembles, we can also estimate uncertainties in the generated forecast. Then we also thought, at the back of our mind, our model, our modeling structure need to be quite flexible. So we need to have a requirement for continual changes in model structures to address newly emerging interventions like vaccinations, and then evolution of transmission novelties like new variants. So our model need to be quite flexible as well. And then the final thing that we also started doing is to develop dashboards to couple data with the models and predictions, so that the latest projections can be made available to decision makers. This is the structure of our model, and as you can see, it's very complicated. These are compartmental models. So the way we model transmission of the pandemic is by looking at simulating, the rate of movement of people from between different groups. So when a novel pandemic comes into a society, initially, all of us are susceptible. The entire community will be in one category, the susceptible category. Susceptible people will come into contact with infected people. These are infectious people of different types. And then they become infected. They go into a class which we call exposed. These are a latent class. They are infected, but they're not infectious as yet. Once you get exposed, you can go into two pathways in COVID-19. One pathway is you become infectious, but you're completely asymptomatic. You don't develop signs of the disease, at all. You will hold disease for 2 to 3 weeks, and then you lose your infection and you become recovered. This is when you become solidly immune to the virus. Okay. The other pathway is you become infectious, but you are pre-symptomatic. You have mild symptoms, and then you have infectious and mild symptomatic cases, and then you transit into the hospitalized cases. These are severe symptoms. And then some of the hospital people will go into ICU, will require ventilations, et cetera, et cetera. Okay. And all the infectious people can recover, as you can see, and become recovered. So they become immune. Okay. This is naturally acquired immunity. We'll look at that later on. And then, we assume that people who die are people who are actually going to ICU, and that's where people die. So that is the structure of the model. Of course, we can now start putting in all kinds of interventions, one of which at that time could be quarantine. You can, some people can be tested, found to be infected, and put into quarantine, right? All the infectious people who are tested. The other thing that we could do is, people initially for containment is to put a lot of people into restricted mobility, into lockdown, which occurred, last March to May. And so people from the susceptible class will move at a particular rate, and they are in restricted mobility. This is the lockdown state. You're staying at home and things. But of course, those people are not completely susceptible, completely locked away from infection, because they will go to markets and whatever, so they can revert back to susceptible and get infected. Okay, and that is controlled by those two parameters, alpha and lambda there. The other thing that you could do is reduce transmission by social mitigation measures. This is physical distancing and face masks. Now, we can write equations for each of those, but it's very hard to parameterize. So here we are fitting the model to data and estimating the level of social protection that you can get, which will reduce beta. Beta is your transmission rate, okay? Then we can bring in the vaccinated class. You can get the first dose, and this is the second dose, booster. But because our vaccines are not 100%, the vaccinated people can also get infected at a particular rate here. Yeah, we can also bring in vaccine refusing class of people. This is a fraction of susceptibles who refuse to take vaccine for whatever reasons. So you can see, this is a highly complicated model, a lot of parameters that we need to estimate. So how do we estimate the parameters? This is the data that we get to fit the model. This data, confirmed infectious cases. These are all belonging to this three particular categories. We also get mortality data. And luckily for us, at the county level, this data has been tracked by the Johns Hopkins University in their database. So all we do is we go in every night, pull down the data, fit the model using the Bayesian calibration that I talked about. And then once you fit the model to the data, we can estimate all those parameters, including the social mitigation measures, and rest of it. Yeah, this is a data-driven model. And therefore, we can localize the model, make it very specific to different counties. Right now, we are supporting about 34 states all across the US. Every county is being modeled. The other thing that we do is try and estimate this independently, the rate of movement susceptible into lockdown and then release from lockdown. That we get from the company called Unicast, which are tracking mobile phone data. This, how much travel has been made by people with mobile phones, right? And for that, we can estimate the lambda here, the rate of people moving into the lockdown state, and then, by movement, how much of people are moving. And that ratio there can give us the rate at which people are staying in lockdown at any given time. If you look at this, this is before the pandemic. After, so once a lockdown took place, 0 means normal movement. Lockdown took place, look what happened. Less and less people were actually moving in the community. Lately, it's beginning to increase again. The other feature of this model is, as I said, sequential updating. Why is this important? Because this is a respiratory infection, and social behaviors are very important. So we need to update our parameters, as the pandemic evolves. Why is this important? I mean, let's say this is the data that we have, okay? The circles are all the data, and this is early part, and this is, the whole stream of data that we have. Suppose we have a model and we only fitted to the first 40% of the data up to here, the closed circles. That is a fitting of our model to data. And then we make projections into the future. Look at our projections. They do not capture the future data. That's because we are locked in to a particular parameter set. And we are saying that parameter set is stable, will not change. If you look at, suppose we take the next block of data, 20%, and you fit the model to data, and then we make the forecast. Now the forecast is capturing the future, but there's a lot of variation. Suppose you take another block of 20%. Now, you're capturing the future, but also restricting the variance. This is when you fit to the first, to 100% of the data. So what this is telling us is, if you just stop with the initial fit, we'll make lousy predictions. We have to sequentially update through time, and that is what we do. We sequentially fit to incoming data. Like I said, every day we go and we do it to 10-day blocks of data. We take 10 days and refit the model to get new parameters, and then we use that model to make the forecast. So how does the model look? Does it capture data? The blue curves are the actual observed daily confirmed cases, and this is for Tampa Bay region. There are 4 counties in Tampa, and this is combined. And the model predictions, the median, remember this is an ensemble of model. We select 500 best fitting models to the data. So we can calculate the median and also the confidence interval, given by those boundaries there. You can see the median is capturing the data, through time. And then once we capture it, we can make the forecast into the future, assuming that these parameters will still hold in the future. So keep that at the back of your mind. We'll come back to the social mandates in a minute. But I just want to show this was a model fitted to March 31st. And at that time, the models were suggesting that it was declining and now is beginning to come back again. Okay, the cases are beginning to climb up. But compare that with the model which was fitted 3 weeks previously. At that time, we were making the prediction, according to the data, that the pandemic is ending. It's just declining over time. Compare that with the latest prediction is showing that the pandemic is coming back, is rising again. So that tells you the importance of sequential updating. This pandemic will change through time. And so we need a very flexible modeling system that can capture those changes through time. So when we started, like I said, the first stage of the pandemic was, it had already arrived in the US. So there's no point thinking about preventing the arrival of the pandemic. It's already arrived. So we switched to how do you contain the pandemic? Remember, initially all of us were susceptible. The danger is the pandemic will burn through all of us and lead to very big waves, very big pandemic outbreaks, right? So the first thing that we go back to what the models were saying. How do we contain that initial outbreak? And that's when they started thinking about lockdowns. And actually lockdowns came from model prediction showing how well, by restricting people's movements and keeping them stay at home mandates will actually stop the susceptible from meeting the infected people. Okay, and by doing that we can flatten the curve. So we modeled what will be the impact of lockdown on infectious cases. We did that modeling in March 2020 for Tampa Bay, and we looked at a low lockdown scenario and a high lockdown scenario. This is simply the number of people who are staying in lockdown. And you can see that in terms of the peaks, the size of the pandemic, it didn't change much. Once again, the black curve is the median, and this is the confidence intervals, 95% confidence intervals. It didn't change the peaks, whether you went to low or high lockdown. Only thing you did in the high lockdown, you just shifted the peak to occur much earlier. And we are modeling from 11th of March onwards. But what the high lockdown did, and that was already very clear, is that it will resolve the pandemic earlier compared to a low lockdown, which will go beyond June. Okay, here by June 19, you would have killed the pandemic. But note the dates. We are saying that if you begin lockdown 11th of May, you have to continue it until June 19. That's when the pandemic will get over. Okay, and And the impact of the lockdown, at that time, policymakers was, we needed to show the real impact of the lockdown. Look at the confirmed cases, look at the y-axis. These are only in hundreds, right, cases occurring per day. But look at if there was no lockdown. Now this is about 200, and this is 250,000 cases would have developed in Tampa Bay if there was no lockdown. That shows the import. If the lockdown just reduced it to about 400, and I mean we're looking at the median 490 cases. Without the lockdown, we would have hit 250,000 cases. So that shows the impact that the lockdown did, because it was preventing the susceptible people from meeting infectors. It killed the pandemic. But it also is giving you a warning. You needed to keep the lockdown going for until June, as we have seen in the previous slide. We can similarly show how containing is going to be very important to safeguard the hospitals, right? And this is looking at peak hospital bed requirements, for low lockdown and high lockdown. Once again, let's focus on the median. We're saying, well, this is the mean. This is the full, confidence interval. 217, 891 hospital beds will be required under the low lockdown scenario at its peak, as opposed to 201 and 751. The importance of making this kind of peak predictions or forecasts is that we can compare to how many beds are available. So we had across the 4 counties, 4,582 beds. So this is showing that the lockdown, will enable us to contain the pandemic below, the threshold, for beds, the capacity, for dealing with hospitalizations. So that was very good news that the lockdown is going to, and this was taken on by policymakers, the importance of maintaining that lockdown. But when it comes to ICU requirements, we only had 494 ICU beds available. If you look at the median, we were fine, right? We were below that 492 threshold. But if you look at the confidence interval, it would have gone up to 810 in the low lockdown. In the high lockdown, 676. So showing that for ICU, we might have to look at a high lockdown scenario, to contain, to safeguard, the hospital capacity to deal with the ICU requirements. So those were showing that the lockdown was really, really going to be very important for containing the early, surge of the pandemic. We needed the lockdown, but there was a warning that the lockdowns needed to be extended to end of July even, because we needed to keep the lockdown going until the pandemic ended. Transmission was broken. If you release it early, we will get resurgence of infections. And this is what the models we showed, in April when we made those predictions. Because that time, many governors were thinking about releasing the lockdown, early May. Some places they were thinking about a phased lockdown release, 10% in May, 25% June, 50% July. And this is our model predictions. If you were to do that, because, if you go back to this slide, we're talking about, okay, yeah, we're talking about this area here. There's a lot of infections there. If you release the lockdown, you're going to let the susceptibles mix, mix with infected. This is infected people, and that will lead to resurgence in the pandemic. And we were making those forecasts already, and the size of the coming, the next wave would have been really big. We are talking about, if you look at the median, about 1.25 or 1.3 million total infected cases at its peak. So that was a warning already. This is not the time we said, to release a lockdown, because you're going to get a wave. One of the reasons for why we were predicting that there will be a resurgence if you have an early release of the lockdown is because look at the recovered cases. This is a number of people who recovered from infection and are immune. Only 0.12% of the Tampa Bay population would have been immune, before the May 1st release. 1 point, that will only increase slightly to 1.3% and then 1.4%. So very few people were getting immune. And the problem with that is as soon as you release the lockdown, there's very little immunity. There's very little herd immunity. Why is immunity very low? That is because, people didn't get infected. People were still susceptible. Remember, naturally acquired immunity, you have to go from susceptible, become infected, and then you become immune. You lose your infection after 2 to 3 weeks, and then you become immune. But because the lockdown kept people from getting infected, this never happened. And because there was very little herd immunity, you were going to get those resurgences. So then we said, when do you have to release the lockdown? And we made simulations. We were saying, like, remember, I said this is confirmed infectious cases, this is total infected cases. We have to we we needed to have kept the lockdown, last year until August, when the pandemic is over. We're looking at the median year. Or July, between July and end of August, or 18th of August, sorry. You know, that's when we needed to have kept the lockdown. At that point, you can release, people because there's no more infected. But the problem with releasing people after the lockdown is, like I said, very few people are immune. That means any new infection that comes into the community will lead to another resurgence because people are still highly susceptible. So that was the scenario, about lockdown. So then, people released the lockdown. May 4th is when the lockdown was released in Florida. So then the situation changed into mitigation. It was no longer containment because the governors, the states decided to release the lockdown because of the economy was hurting. So then they thought, okay, the way is to release the lockdown, but maintain social measures. This could be face masks and physical distancing. So what impact, so how do we manage this, to mitigate the resurgence of the pandemic as a result of early release of lockdown? And here I'm showing simulations that we did in the fall, last year, 2020, about November time. And that time we are saying, taking the latest model, what would be the scenarios that we can look for and how do we contain the coming pandemic, the coming wave, which we were predicting is going to occur, 27th of January to 19th of February. The peaks are going to occur at that time, following fall 2020. And here I'm showing simulations. This is current social measures. That time, remember, there was no vaccines, only NPIs, social measures. Here, when I say social measures, is that parameter D, physical distancing and face masks. And that is saying if you were to continue with that, you will get a peak. You will get, much bigger sized, resurgence occurring, compared to the summer wave. You will get another wave, will be much bigger than the summer wave. This will be the winter wave. At its peak, there'll be 18,000 cases. We're talking about daily infectious cases here, okay? But what if you were to increase the social measures, just moderately, about 10%, get 10% of the people, more people to be compliant. That will reduce the size of the coming wave. If you were to increase it by 20% of people getting get 20% more people compliant, then you will reduce. You'll become almost similar to the July, the summer wave, 6,519 of February. But what if we were to release the social measures? And this is only by 10% people not compliant with social measures, then you'll get a huge peak, 38,000, and that'll occur on January 27th. Okay, so this is what we were giving policymakers, and we were emphasizing the importance of increasing social measures, to contain the coming wave, which occurred, in January. And we made similar predictions for hospital cases and ICU cases. If you combine the two, we, hospital capacity depends on what the hospital has been used for, right? At that time, they thought that hospitals normally work at 75% occupancy. That means, if you look at total hospital-based and ICU beds, there were 9,700 beds, totally in the Tampa Bay. But 75% of them are already occupied for other conditions. That means you have 2,441 potentially that could be used for COVID cases. That is your target. You want to bring cases, hospital cases below. And once again, we're showing if you were to keep on the social measures that were apparent or that were applicable, in November, you will overshoot hospital capacity. You'll need 6,300 beds, and you only have 2,441, right? Unless you start, shifting the other patients to care for, COVID patients. But if you increase social measures by 10%, you'll need only 5,300. If you were to increase by 20%, then you will be below, the capacity, and therefore you can safely, deal with the coming requirements. But if it was 10% release in social measures, look, it'll shoot up to 12,000 beds, and that will completely overwhelm. The total capacity is only 9,700. You'll overshoot capacity. And so this focus minds, once again, we were talking to the mayor here, we were talking to health departments in Florida, said the importance of messaging about social measures to contain the coming wave. So how did the data look like? We were saying, remember, we were saying that with current social measures, you'll develop 18,000. This is all forecast, right? No data into the future, which we made in November. 18,000 cases will occur at its peak on February 13th. So did that actually occur? Okay, so we made the prediction somewhere around here. And, so we were saying 18,000, but this is now daily confirmed cases. So you divide the 18,000 by 5, that's the difference. So look at the cases, the blue, 3,000 cases, but it occurred the first week of January. So 3,000 times 5 is 15,000 daily infectious cases. And we were predicting towards the first, remember, the first week of February, the peak will occur, 18,000 cases. We were getting the cases almost right because we were getting 15,000 actually observed cases were occurring. This is confirmed cases, but daily infectious cases, like I said, you multiply 5 times, you get 15,000, cases. But it was occurring much earlier. It occurred in the first week of, January, rather than our prediction, which was, the first week of February. 18,000. So the cases were almost, we were in the ballpark, but we missed it. It occurred much earlier than what we were predicting. But we were in the ballpark area, okay? And we'll come back to this in a minute. Okay. So then the question we asked was, why was this resurgence occurring, in early part of this year? What happened? One thing that we need to see is if you look at the pandemic, as the pandemic increased, remember I said these things always co-evolve. As cases increased, face mask mandates were imposed, bars were closed. As soon as that happened, after a lag, cases came down. But as cases came down, we reopened schools, bars were reopened. As soon as you did that, cases rose again. And this is what I mean by that co-evolution between social behavior and the pandemic, right? And as the pandemic started increasing and people were alarmed in December, face mask mandates were reimposed in Tampa, and then the vaccinations began to take place. As soon as that took place, cases began to come down again, okay? And this was the prediction that we made on the 9th of March, okay? So once again, showing the social mitigation mandates led to declines in cases. So the importance of social mitigation measures. While reopenings before transmission ended led to resurgence in cases. And this was looking at why were we predicting that January will get a spike, a second wave. This is the looking at time varying. Remember, we were getting unicast data, mobile phone data. A lot of people. This is a fraction of the population in Tampa under restricted movement. During the lockdown, a lot of people were under restricted movement, but over time, that declined. So in December, during Christmas and in New Year, only about 30% of the people were under restricted movement. So one of the reasons for the rise in January was less people under restricted movement. This is social protection, protection because of social measures. During the lockdown, 70% protection, physical distancing, masks. But from September onwards, that declined, so that in December it was only 58. Those two combined, to give rise to the January rise. Then we have the latest, this is the advent of the vaccinations and variants. So we needed to rejig our model, so we now have two variants. You got the susceptible people, they get infected with one particular variant. This is the old variant. You get the asymptomatic, get recovered, and then you get into the symptomatic pathways and you get recovered. And then some of the susceptibles can get infected with the new variant. And that will get, E2. This is all the new variants. Once again, asymptomatic, and then you go into symptomatic pathways, and then you get another, and then you recover. So R is the recovery from the old variant. R2 is recovery from the new variant. Together, these are the fraction of people who've got naturally acquired immunity. Now, vaccination. Susceptible people get vaccinated, and then you get the boosted dose, right? And those people who get into those classes are the vaccine, and give rise to vaccine-induced immunity. This is artificial, man-made immunity. So together, herd immunity under vaccination is R plus R2 plus V fraction and plus B. So that is herd immunity, that can be generated. So then we go back, like this is, we have seen the slide again. You'll see that, the latest, up to March 31st, cases are beginning to rise instead of going down from March 9th onwards, the previous prediction. Now cases are beginning to go up. So the question is why? Despite vaccinations started taking place, middle of December, and there was a mask mandate as well. And there's social measures as well. Despite all that, cases are beginning to rise. Is it because of the new variant? Now we have the model to test that, or something else, or is it because social measures have dropped? And this is doing reasons for the resurgence, so we can use the model to try and investigate. This is looking at the UK variant 117, variant. And this is saying, and we're making the forecast from 1st of March onwards. And we are assuming 5% of infected population were carrying the B117 variant from March 1st. And we're simulating impact of 50% versus 75% levels of contagions of that particular variant. Now, when we make the prediction, this is the old variant, the black curve. It is declining from March, right? This is the actual data. So that's not capturing the actual data. This is the new variant, the lime-colored curve. Under current social measures and current vaccination rate, from March 1st onwards. And this is the combined cases due to the two variants. They're not capturing this rise in cases. And this is assuming 50% contagiousness, for the new variant. Now we're looking at 75.
Michael,
what if, yeah.
I'm sorry to interrupt you. We have a few minutes
yes.
and a couple of questions. Yeah.
Okay. Yeah. So this is the 75% variant. That also is not capturing the increase in cases, right? So what is going on? So then we said, what if this is looking at 50% variant, what if social measures were decreased by 25%? Now it's beginning to capture the new, the recent rise in cases. So, but if it's 75%, it overwhelms, it's much, it just explodes. So it's not the case. So what we are seeing here is a decline in social measures recently, and also the new variant is beginning to play a role. And it is mostly the 50% contagious variant. I think that's the end. And then we are asking, what if, in, how do we control the new variant? You know, and here, vaccinations were increased by 2 times. And if you were to increase the vaccination, then we can still control. There'll be a small rise in cases, but over time that can be controlled. And even with the 75%, you'll get a spike in cases, but because social measures are continuing, and now we have increased the vaccination 2 times, we can decrease, the impact of the new variant, so that by November, the pandemic is over. So I think, okay, I think I'll stop there, right?
Thank you so much, Dr. Michael. I mean, it's mesmerizing the amount of work that this requires. I think when people think about modeling for COVID-19, sometimes we don't appreciate how complex this model is and how many different parameters you need to consider, and how do you get to data to confirm that those parameters are appropriate, and then you need to feed that to the reality and make sure that the models are within, that performing within a margin of error, let's say. So really, it's a monumental task, and it's really important for us to also better prepare for what's in front of us, right? So how do we prepare for surge capacity, surge demand in the hospitals? How do we prepare for or how do we help politicians, decision makers, make decisions regarding mask mandates or encouraging social behaviors that are needed? There are a lot of questions that I myself would ask, but I want to give
Yeah.
I want to give time for the questions from the audience. And a couple of questions are related to how do we account for economic and mental health impact of lockdowns in the models? Because it seems like we usually talk about the impact on COVID-19 and cases of excess death, but the question is, what about these other important outcomes as well?
Yeah, I mean, that is a good question, right? Because so social behavior is very difficult to model. I'll tell you that. So we are doing it very crudely in terms of compliance with social measures, which we captured through that parameter D by fitting to cases. Cases are changing all the time, and movement is changing all the time. So we got some independent data on movement. People are now moving very freely, as we have seen, right? So, and that is also going back to what they perceive is happening in the community with the interventions. Vaccinations have brought this maybe false impression that we've got the pandemic under control. But if you look at vaccinations, we have targeted older people. They are not the dominant group which are transmitting the pandemic. It's the 20 to 49. It is the 20 to 49 age group which are the dominant group, right? So as long if we don't tackle them, if you don't get them vaccinated, the pandemic is going to be here. This transmission is going to occur. Now, because the vaccines have rolled out, many people are beginning to feel that it's all over. The vaccines are going to do this work. So they are less compliant with social measures. And we can see that when we walk out on the streets and things. Very few people are wearing masks anymore. I used to see initially lots of people were, but now nobody. In the shops, certainly, you have to wear a mask. So it is about the social perception of the disease. Now, coming back to your question, it's very difficult to look at, where is the data on the mental, aspect, the mental problems that will arise. Very little data out there. There are studies being done, but it's very hard to model that, using the equations that we actually develop. We can model fear, in terms of response. How do communities respond? That we have a handle how to model. Like I said, people are fearful when cases rise, and that is reflected in the parameter D. People are less fearful when cases drop, and that will be reflected in the parameter D. So that's how we are modeling this for now. We haven't looked at mental problems. And then in terms of the economy, yes, there are big models being built. looking at what impact if workers don't go, if you know if people are in lockdown, you reduce the number of people who are working, so productivity drops. So there's a lot of work done on the economic side of things. I think I'll stop there.
Thank you very much. It's very insightful to understand how difficult behavioral health is, and mental health as well. And there are some reports, as you said, it's difficult to model those outcomes, and also we would need to account underreporting people who are experiencing a mental health issues but are just not seeking out help
Yeah.
as they should. So definitely thanks for the question to the audience, and thank you for your answer, Dr. Michael. Another common question, relatively common in our audience, has been, how do we help impoverished countries leverage these models? Is there any manner to do capacity building or collaborations, or how do we account also for the the fact that in some of these developing countries data can be not reliable, 100% reliable? There are constant fluctuations in the measures, in the mechanisms, and sometimes they even rectify what they had reported previously. So how do we account this in such environment?
I mean, that is a really, really good question, because we've started doing some work in India and Ecuador. In India, for example, as you said, data is a problem. You know, over here we can get, for example, the mobile phone data. It's very easy to get. Companies are collecting the data. That tells us how much people are mixing in the community, and that's very important. Now, we don't get that kind of data in other countries. That those data are limited and very restricted, very limited in their scope. So many people don't have mobile phones in many parts of the world, so it's very hard to get that data. So there, all we can do is scenarios. What if, kind of scenarios. What if this many fraction of the people were to comply? Then this is what will happen. Just like in our lockdown scenarios, we can't be data driven. We can only do theoretical explorations of what might happen. For example, in Ecuador, we started modeling. The important thing in Ecuador was people were using buses, to travel for work, and that is not the case over here, right? So it's very different culture, and so Ecuador was trying to stop movement between in their provinces and things like that, and we could use that model, but we had no data on transportation. We know that people are taking buses, but it's very difficult to get data on the rate at which people are taking buses and things, because that is the central, kind of connectivity between, provinces, in Ecuador. And many of these people are in the informal sector. India is also, the large proportion of people who are working are in the informal sector, where you have very little statistics. So under those scenarios, the best thing you can do is, make some informed guesses about the parameters and then run scenarios.
Thank you so much. Again, very insightful. Your comments about transportation in Ecuador, and the issues in India. We've worked. I've worked both in Ecuador and India, and can understand that. And in our audience, we have people from other parts of the world that can relate to those experiences. And it's important to know how can we overcome the things with the limitations that we have.
Yeah.
Understood. I think we might have time for one more question, and that is related to the Johnson and Johnson vaccine. One of our audience members says that it has been stopped by the FDA this morning, and what that impact would that impact your predictions for local, national, and global impact of the pandemic?
Yeah. I mean, right now we are in the arms race. We need to get vaccines out as fast as possible, as long as they are effective against the variants, currently, because the virus is mutating all the time. People are becoming relaxed in their compliance with social measures. So we are seeing the uptick in cases, recently. So what that means is two things, that if cases begin to spread more in the younger population, mutations are always going to occur. One problem would be a mutant may arise which will be completely impervious to the vaccines that we have. And that will be, spelling huge trouble, because they can counter, what the vaccines are doing in the immune response. And if that were to occur, then we're back to square one. We need to have booster vaccines, to counter that particular variant. So that is a major, major problem. So, what we are trying to say is we have to push, get herd immunity, in the population. The last two slides, which I didn't go through, is asking the question, when can we stop? When can we reopen fully? That is when you get herd immunity. So we need to get 80 to 85% of the people immunized. And like I said, immunity is two ways, right? Through the vaccines and through naturally acquired immunity. Naturally acquired immunity is very low because of physical, social measures of preventing people from getting infected. So very low. Right now, we are about 40% in the US, herd immunity. And that needs to go up to 80%. And the only way we can get that is by ramping up vaccination. 2 times, 3 times the current rate. So the Johnson and Johnson thing is a blow because we were hoping that the Johnson and Johnson vaccine can come in and help us ramp up the vaccination rates, so that by June, July we'll reach herd immunity. That's when we can fully reopen. So this is a setback. So the other vaccine manufacturers have to step up. And then we have the anti-vaxxers problem, right? People who are refusing to take vaccine, and that is going to be a problem that we are going to have to confront. So the scenarios in the future, and this is the current modeling work they were doing, is going to be highly spatial. You're going to get, just this is like a fire, a forest fire. When the fire is damped, when the fire is over, you'll have embers burning here and there. And that is how it's going to be when you have anti-vaxxers. You're going to be groups of people who are going to get infected, clusters of infection. But because, within the next month or two, we will get 60% of the people vaccinated, even without the Johnson and Johnson vaccine. Now, if people don't take the vaccine, they might be in small parts of the county, in the US. You'll get clusters of infection occurring, but that's not going to spread to the general population because the general population are vaccinated, 60%. So you'll have the small spikes, outbreaks occurring throughout. And that's how I think this is going to play out. So then the policymakers will have to get spatial data, and target that groups somehow. They are also vaccine hesitancy, right? People are willing to take the vaccine, but they're hesitant because of all kinds of cultural issues and things. So we need to go and actually take the vaccines to those people and convince them to take the vaccines.
Excellent. Thank you so much. There are interesting questions that we couldn't get to.
I know.
About the role of modeling in decision making and policy, and about the surge, the winter surge in 2021. I apologize. We weren't able to go through them, but we do appreciate all of our audience, their time and their interest in today's talk. And of course, Dr. Michael, we are greatly indebted for you taking the time to give us this talk and help us understand better the role of modeling in pandemic preparedness and control and response.
All right. Thank you so much, everybody. Thank you.